Okay, guys, we're going to continue with the newer anti-epileptic medications. Lamotrigine is also one of those new ones used for epilepsy. And we use that for partial seizures where they'll kind of just have like that blackout. We're using for the tonic-clonic seizures. Those are the ones where they may be kind of flopping around. We can also double dip and use it as a bipolar medication, 'cause a lot of these medications help to kind of regulate neurologic function as well. Side effects are going to include drowsiness and abdominal pain. It can cause some dry mouth and some dizziness. So make sure that you're helping your patients ambulate. Make sure that you're monitoring for postural hypotension. They should not be driving or utilizing heavy machinery. Adverse reactions can be life-threatening rashes like SJS or Stevens-Johnson's, and it can cause folic acid deficiency. So a lot of times when docs give it, they're going to give supplemental folic acid to those patients. That it interacts with aspirin, several medications, aspirin, oral contraceptives. So if it interferes with oral contraceptives, moms should use, or ladies rather, should use backup methods for pregnancy. Also, it interferes with drugs for HIV, so this would not be a candidate. This drug would not be a candidate for patients who have HIV or AIDS, TB medications, because it has a tendency of lowering the immune system. So definitely, if your patients begin to develop, high fevers, cough, anything like that, that may be opening them up to secondary infections. So as nurses, make sure you're monitoring vital signs closely because it can lower the immune system. Make sure you look closely at that temperature. Make sure you're assessing the skin for any impending rashes. Um, Also, do not stop it abruptly because as we say, then it's going to interfere with the threshold or the excitability of the neurons, so it can bring seizures on. Lacosamides are also used for epilepsy, and they also control the actual neuron excitability so it doesn't get to that threshold. Side effects of lacosamide is going to include headaches and dizziness. You might see some blurred vision and fatigue. Also, they may have some euphoria, and that can lead to a psychological dependence. So if you have a patient that's going through epilepsy, they may already be depressed because of it. They take this medication, makes them feel good. So they start having psychological dependence on it. They enjoy the way that it makes them feel. And also adverse reactions, as with many of them, are going to be orthostatic hypotension. So make sure you're being very careful with them, and syncope, which can be dizziness from a blood pressure drop. Here are the interactions that go along with the lacosamides. You can read those at your leisure. But as for nursing implications, always assess vital signs first, okay? Always assess those vital signs, especially because they cause orthostatic hypotension. Look at the blood pressure, look at the heart rate. Look at the blood pressure, look at the heart rate. If they develop any changes in vision, definitely have them contact you and let the healthcare provider know so that they can perhaps be switched off to another medication. Okay. All righty. And then we have topiramine or Topamax. And this medication also was originally utilized for migraines, for chronic migraines, but has since been very useful in working with minimizing the excitation of the brain. So it doesn't raise that threshold. It's just going to, minimize the excitation of the blood of the brain so that you don't have that seizure impending. Side effects include drowsiness, dizziness, and fatigue. Also, patients may report changes in taste of things. So sometimes they may have like a metallic-y or a meaty taste in their mouth that consistently goes on. It can cause an adverse reaction, some memory impairment, and some electrolyte imbalances, in particular low phosphorus and maybe so if it has low phosphorus, it can cause high levels of calcium and vice versa. So make sure you're monitoring those electrolyte levels. All right, this is several interactions. You can take a look at that at your leisure. All right, so now let's talk about our BRMs. And BRMs are drugs that modify the immune response to immunity and inflammation. Okay, so these are medications that are going to modify the immune response to immunity and inflammation. So if there is something in the body that causes a level of inflammation, it's going to control that and mitigate that. And then we have monoclonal antibodies, and what they do is they attack or inactivate or destroy lymphocytes that will definitely affect the myelin sheath. So sometimes when you have a severe immune issue in the brain, it can begin to destroy those myelin sheaths. And remember, we talk a little bit about that insulation that goes along the axon to help increase the amount of electric activity that goes on. So these monoclonals, that's how they're going to work. They're going to work to minimize that lymphocyte destruction of the myelin sheaths themselves. All right, and then we have neurologic drugs. You can read those at your leisure. Okie dokie, now let's talk about mental health. Okay, let's talk a little bit about mental health and the drugs that we utilize. Okay, so with mental health, oftentimes there are neurotransmitter disruptions, and of course there can be. I don't want you to think that that's the only reason for mental health. There's several things that affect it. It can be situation, it can be trauma, it can be history, but then ultimately those actions can then disrupt neurotransmitters. So the transmitters that are often involved in mental illness or mental health are serotonin, dopamine, norepinephrine, your GABAs, acetylcholine, and histamine. So we're looking more so at the physiological mechanism behind psychological dysfunction. So let's talk about what is mental health. And in mental health, it is a condition in which a person's experiences are changed by alterations in behavior or in motion and motions or both. Okay, so those patients that may have a change or perceived um, reality might have, for example, hallucinations, be it auditory or be it visual hallucinations. They may feel persecutions where someone's out to get them or people don't like them, when in all actuality, no one's really paying much attention to them, but they don't see it that way. They feel that this person is perhaps out to get them. In issues of depression or bipolar depression, you may have instances where the person's, maybe their dopamines and serotonin levels are off, so it makes them exceptionally sad. And then sometimes they may be elevated where they have issues of elation and excitement. Okay. So let's talk a little bit about some of the medications that we use. We use sedative and hypnotics. Now, there is a difference between a sedative and a hypnotic, okay? A sedative relaxes a patient. A hypnotic puts you to sleep. Now, that doesn't mean that a sedative will not have hypnotic principles. So, for example, let's say you have a patient that has anxiety and we give them some Ativan. Now, Ativan is historically a sedative, it's for calming and quelling anxiety. Now, a side effect of getting them to calm down and be cool can be hypnotic. They can fall asleep, okay? So a sedative would be like your Ativan and your Xanax, maybe even your Visceral. And a hypnotic is going to be like your Trazodone to help you with sleep, or melatonin to help you with sleep, or Ambien. Its purpose is to help you with sleep, okay? And okay, so we said that it's used to, relax patients. We can do it for people that have insomnia, if they need to just get a good night rest, especially if you're in a hospital or you're in a mental hospital. It's pretty difficult being away from your family, away from what you know, not being able to see people the way that you want to, or if you're put in a room with somebody you don't know, you're nervous, you're scared. Yeah, you're probably not going to sleep well. It might be cold in there, so we can give, either an Ativan or a Xanax to kind of calm you down, or a Visceral, or we can give you a hypnotic to induce that level of sleep. Okay. All righty. So side effects of sedatives and hypnotics are going to be drowsiness, because that's pretty much the purpose of them, right? They can induce memory loss, especially the big boy like Ambien. You can do crazy things the night, right before you go to bed and don't remember a thing. Okay. They can lead to addiction. And when I say addiction, not like that greedy, ooh, I want it kind of addiction, more so If you continue to take them, unfortunately, you won't be able to sleep without them. So that does occur. And with a lot of this, with some of the hypnotics, in particular Ambien, which is the beast, can induce sleepwalking. So make sure when your patients are taking Ambien for the first time, usually the doctors are going to prescribe the lowest dose because you don't know how it's going to affect. I would always suggest if you're going to give those hypnotics to make sure that they take it while they're in bed because it does work relatively rapidly. And when it does, you are down for the count. So try to take it when you're in bed, not, oh, I'm getting ready to hop in the shower. Let me take an Ambien. No, not at all. Do it while they are in bed. Okay. If they are propensity of sleepwalking, we always advise family members to take things like their keys, their car keys away, and things so that they don't get in a car, because they're sleepwalking. They don't necessarily know what's going on. Might get behind the wheel and start driving out there. Okay, so take the car keys from them. Okay, interactions with sedatives and hypnotics are going to be caffeine, fluoroquinolone antibiotics, and oral contraceptives. I will also say alcohol because alcohol also has that sedative and hypnotic action to it. So no alcohol with that as well. Okay. So here we go. For sedatives and hypnotics, they should not be taking longer than 2 weeks. If the patient still needs them for 2 weeks, then the doc may have to look at another alternative. Perhaps they may give Seroquel. Seroquel is a little bit better if they're having problems with sleeping and anxiety. Seroquel works great. Not necessarily as habit forming, and it's more of a chronic disorder for those patients. Ativan and Xanax, they try not to put you on that very long. They want to really get to the reason why you're experiencing these levels of anxiety. Now, if it's just for, hey, I'm going to fly and I need a little hit, a little Ativan, they'll give you 5 pills, you'll be fine. But if you're finding chronic anxiety, the doc really is going to want to get to the bottom of why, because anytime you're dealing with psych issues, it's not just a matter of medication. Therapy has to be included in there. Medication is that quick fix, but the therapy is really going to be the hallmark of getting better for mental health. No operating heavy machinery. So definitely take the car keys if the need be. Make sure they take it at bed. Try to take it a little earlier in the day, not the day, in the night, because you don't know how the medication is going to act. So you may want to take it a little earlier in the night. Also, no alcohol and no caffeine with these medications. All right, so here are some of the agents we're going to talk about: some anti-anxiety meds, antidepressants, antipsychotics, anti-maniacs, and we already talked about the sedatives and hypnotics. So let's talk, we're going to delve more so into anti-anxiety medications, and we use those as those sedative medications. Anxiety is exceptionally common. Okay, give me just a sec, guys. I just have to pause it.